In this lecture, we will discuss renal tubular acidosis, RTA, a group of kidney disorders that affect the body's acid-base balance. We will explore the genetic basis of RTA, its different types, clinical features, diagnosis, management, and its associations with other renal disorders. Let's begin. Renal tubular acidosis can be both acquired and inherited. Genetic mutations play a crucial role in the development of inherited forms of RTA. Many genes encoding critical transporters and enzymes involved in renal acid-base regulation have been identified and implicated in different subtypes of RTA. These include genes encoding sodium bicarbonate cotransporter, carbonic anhydrase, proton ATPase, and chloride ion channel. Mutations in these genes can result in altered function or expression of these proteins, leading to impaired acid-base regulation. Distal renal tubular acidosis, type 1 RTA, is a common form of RTA. It leads to reduced urinary acidification capacity due to a defect in the distal renal tubule's ability to excrete hydrogen ions. Diagnostic criteria include high urine pH, low serum bicarbonate levels, and an inability to acidify urine despite systemic acidosis. Clinical features can include polyuria, polydipsia, growth failure in children, nephrolithiasis, and recurrent urinary tract infections. Proximal renal tubular acidosis, type 2, is caused by impaired bicarbonate reabsorption in the kidneys, leading to a loss of bicarbonate in urine. Possible causes include autoimmune diseases, medications, and genetic conditions. Symptoms may include metabolic acidosis and kidney dysfunction. In type 3 renal tubular acidosis, RTA, both distal and proximal renal tubules are affected, leading to acid-base regulation impairment. Symptoms can include metabolic acidosis, nephrocalcinosis, and urinary stones. Treatment typically involves a combination of alkali supplementation, electrolyte management, and addressing complications. Pediatric populations with RTA face unique challenges due to age-specific factors. Type 1 RTA is common in infants and young children, while type 2 or 3 RTA is seen in older children and adolescents. Accurate diagnosis requires thorough evaluation of clinical, laboratory, and radiological findings. Early intervention with alkali therapy, nutrition support, and growth monitoring is crucial for favorable outcomes. Renal tubular acidosis predisposes individuals to the development of renal stones. The underlying mechanisms involve altered urinary pH, leading to increased supersaturation of stone-forming substances such as calcium oxalate or calcium phosphate. Risk factors for stone formation in RTA include persistent acidic urine, hypercalciuria, and hypocytaturia. Preventive strategies include adequate hydration, dietary modifications, and medications such as citrate supplementation to increase urinary citrate levels and decrease stone formation. Metabolic bone disease, including bone demineralization and osteomalacia, is a common manifestation of RTA. Acid-base imbalance, particularly metabolic acidosis, plays a significant role in bone health. Chronic acidosis can lead to increased bone resorption, impaired bone formation, and mineralization defects. Monitoring bone health, optimizing acid-base balance through alkali therapy, and ensuring an adequate intake of calcium and vitamin D are crucial for preventing and managing metabolic bone disease in patients with RTA. Electrolyte abnormalities commonly associated with RTA are hypokalemia and hyperchloremia. Hypokalemia can occur due to renal potassium wasting secondary to increased distal tubular flow rate and impaired potassium reabsorption. Hyperchloremia results from the defective renal acidification mechanism and reduced bicarbonate reabsorption in the proximal tubules. These electrolyte imbalances can have significant clinical implications, including cardiac arrhythmias, muscle weakness, and metabolic disturbances. Correcting and monitoring these electrolyte abnormalities are essential components of RTA management. RTA can be associated with other renal disorders, further complicating the clinical picture. For example, patients with nephrolithiasis may have underlying tubular acidosis, contributing to stone formation. Polycystic kidney disease and Fanconi syndrome can also present with a combination of tubular acidosis and additional renal tubular defects. Understanding these associations and their underlying mechanisms is vital for comprehensive patient management and improving outcomes. Renal transplantation is considered the definitive treatment for end-stage renal disease associated with RTA. However, specific challenges exist in these patients, including the potential recurrence of RTA in the transplanted kidney. Close monitoring of acid-base status, electrolyte balance, and renal function is essential in the post-transplant period. Medications, such as calcineurin inhibitors and diuretics, may need to be adjusted judiciously to optimize acid-base balance, prevent rejection, and maintain graft function. Research into novel therapeutic approaches for RTA is ongoing. Various pharmacological agents targeting specific defects in renal acid-base handling are being investigated in preclinical and clinical settings. These include inhibitors or modulators of specific transporters or enzymes involved in acid-base regulation. Developing targeted therapies holds promise for improving the management of RTA, especially in cases resistant to conventional treatment. Primary RTA can sometimes be challenging to diagnose due to overlapping clinical features with other acid-base disorders. Differential diagnosis involves considering various conditions such as chronic renal failure, diarrhea, type 4 RTA, and certain medications. Diagnostic criteria, including laboratory measurements, urinary indices, and response to alkaline therapy, can aid in distinguishing primary tubular acidosis from other acid-base disturbances. Accurate diagnosis is crucial for devising appropriate treatment strategies and optimizing patient outcomes. In conclusion, renal tubular acidosis is a complex group of kidney disorders with impaired acid-base regulation. Understanding its genetic basis, clinical features, and diagnostic criteria is crucial for accurate diagnosis and targeted treatment. RTA is associated with various renal complications, emphasizing the need for a holistic approach to patient care. Advances in renal transplantation and ongoing research offer hope for improved outcomes. As future physicians, it is important to stay updated on the latest developments in RTA management for the benefit of our patients.